I'm Dr. Timothy Brown. I'm a board-certified obstetrician and gynecologist and have been in mostly solo private practice for more than 25 years. I've been pretty much immersed in various aspects of health information technology over the past 3 years. I've been implementing an electronic health record in my own office for more than a year, and I have a master's in medical informatics from Northwestern University. The purpose of this presentation is to look at electronic health records and the current government incentives from the view of a small private practice physician. Let me first give you some pertinent acronyms. These have become sufficiently common that the full name is usually not used. Health information technology is the umbrella term for everything. Medical informatics concerns the management of all aspects of HIT. EHR is often used interchangeably with EMR, or electronic medical record, although technically it should be the broader and more inclusive term. Health information exchanges are state-sponsored, federally subsidized clearinghouses designed to interconnect EHRs across the country. CPOE refers to entering orders within an EHR and is a critical stage in the implementation of hospital EHRs. Clinical decision support is the computer helping and checking on clinical management, and if done poorly is simply distracting and annoying. One of the earliest and most successful applications of HIT has been in radiology, and to manage all of those digital pictures, they need a picture archiving and communication system. The American Recovery and Reinvestment Act of 2009 addressed HIT significantly. That portion of ARRA is the HITECH Act, and the ONC was mandated to administer the various initiatives in HITECH. The first national coordinator was Dr. David Blumenthal, and the position is now held by Dr. Farzad Mostashari. HIMSS is the largest and most active HIT organization. CMS is, of course, Medicare, and PACOS is the online enrollment site for CMS, where you have to be registered to collect your money. An old Sioux Indian proverb states that when you realize you're riding a dead horse, the best strategy is to dismount. Of course, we don't always give in to the inevitable quite so easily, and so we come up with various alternative strategies. I've selected a few of the most pertinent, the bottom two in particular, that most reflect our approach in the current situation. The dead horse in this case is the traditional paper medical record. It is bulky and awkward, often illegible and incomplete, as we are all aware. God forbid we have a fire or flood. Think of what happened during Hurricane Katrina. However, the alternative has some issues as well that make us reluctant to dismount from that horse. This is what the business world calls a SWOT analysis, a brief one. The electronic health record is obviously compact, searchable, organized, and legible, but has issues with security and reliability, variable standards, and does not manage free text well. Issues not encountered by a paper record, largely because the paper record is bulky and awkward. These issues are being actively and aggressively addressed. The great vision of the EHR is that one's record can be available wherever and whenever we need it, and that we can easily tap into the vast store of medical information to inform and guide medical management. Standing in the way of that is cost. Direct costs of software and implementation, indirect costs of infrastructure improvements and workforce retraining, a substantial loss of productivity in the early stages, and the fact that change is never easy. In spite of that, the momentum to get this done is considerable, and the government is fully behind it. Hospitals, as well as large medical groups, appreciate significant benefits to HIT, some of which are noted here, and have been moving toward greater utilization and more comprehensive integration even before the HITECH incentives. On the other hand, few of these benefits to the smaller physician practices actually are profitable, at least over the short term, while they are being asked to shoulder significant costs. It has long been recognized that the societal benefits of the EHR do not readily translate to a return on investment to the individual physician. which finally led to the high-tech incentives. So how did we get here, and where are we going? This landmark study by the Institute of Medicine estimated that 44,000 to 98,000 Americans die each year from medical error, the equivalent of 2 jumbo jets crashing each day with no survivors, and galvanized interest in electronic records as a way of eliminating illegible orders and other errors. President George W. Bush, in his State of the Union address, declared a goal that all Americans should have electronic records by 2015. This started a process which, among other things, led to high-tech, which provides real funding to the tune of $20.6 billion to help accomplish this. These high-tech incentive payments require the demonstration of meaningful use of EHRs, and the Stage 1 definition of what this means was finalized in July of 2010. Registration started at the beginning of 2011, and over $30 million have already been paid out. Stage 2 meaningful use requirements will apply to the first wave beginning in 2013, and Stage 3 possibly in 2015, when the penalties will also begin for those who have chosen not to participate. This is the physician incentive program. Medicare will pay $44,000 over 5 years based on a maximum of 75% of allowed charges. In other words, the first-year payment of $18,000 will be paid only to those having a minimum of $24,000 in allowed Medicare charges. Hospital-based physicians are not eligible. They are defined as providing at least 90% of their services using site-of-service codes 21 and 23. The Medicaid program will pay more, but requires at least 30% of the practice, 20% for pediatricians, to be Medicaid. Failure to demonstrate meaningful use of a certified EHR will eventually result in decreased reimbursement, and as Medicare goes, private insurance is likely to follow. Since meaningful use requires a 90-day attestation period, the latest certified EHR can be implemented and still qualify for the full incentive is October 1st, 2012. These are the stated goals of meaningful use. These are inarguably good things to do, but, as usual, the devil's in the details. For Stage 1, there are 15 core requirements and 5 menu requirements. There are various summary lists of the core requirements, but this one, brought to us by Dr. Ross Martin, is succinct. And these are the menu options. Now let's break them down in a little more of a manageable fashion. Let's start with electronic prescribing. Start with your allergy list and a medication list for 80% of your patients, which might require that you do a medication reconciliation. CPOE means that 30% of the time you order the drug through the EHR. Then that should generate a formulary check occasionally, as well as a drug interaction check. Finally, send 40% of your prescriptions electronically, as opposed to a written script or fax or phone call. You are now a third of the way to meaningful use. A certified EHR should be able to do a number of things without much additional effort on your part. Just get the data in. It must be able to send data to an HIE, an immunization registry, or public health agency. Whether they are able to accept it is their problem. You should easily be able to generate an electronic copy of a chart, which incidentally is an EHR HIPAA requirement, as well as generate transfer or referral care summaries. Finally, you should be able to search for and generate a list of patients with a particular condition, which could be as simple as a list of current pregnancies in an OBGYN office. In its wisdom, the government wants us to provide half of our patients with summaries of their visits. You will find a patient portal in any certified EHR, which will allow the required 10% of patients to access the results. And this is clearly also the easiest way to make their visit summaries available. Security and privacy concerns may limit the usefulness otherwise of the patient portal. The final requirements simply cannot be managed without more active involvement from the provider, and most are core requirements. The risk analysis is simply a reinforcement of standard HIPAA requirements and should be done periodically in any event. 80% of the patients will need problem lists, which cannot be appropriately delegated. The certified EHR should have a number of CDS options to choose from, and likewise, the CMS e-measures will need to be reviewed and the appropriate ones selected before turning things over to the EHR to collect and report the proper data. For patient education, decisions obviously have to be made regarding the type and quality of any educational materials used. And that's it. Simple, right? The next step is to make sure you are registered on PACOS, and then it costs nothing to register for meaningful use, even if you ultimately decide against it. The two government references are really quite well organized and provide a wealth of information. High-tech answers I have found particularly useful, and physicians can sign up for their virtual learning center at no charge. Finally, check out this video, which summarizes everything in 3 minutes. I will be happy to take questions and can be reached through my website at timothybrownmd.com. Thank you for your time.